So as we talk about, guys, we try to really spread out the CEs between medical and cardiac and trauma, pediatric, OB to meet all of our qualifications for the National Registry for Texas. Today we're going to be into the pediatric section. We're going to be talking about pediatric, medical, and trauma. Now, National Registry in the state of Texas doesn't recognize the separation into it's just pediatrics. So for both of these, the state will be pediatrics, and on the National Registry side, remember OB and PD are tied together. So to meet that. So some of the objectives today, we want to talk about the unique presentation of the infant and pediatric seizures. And yes, I know we talked about seizures last month, but we've got some points that we want to really push with this seizure thing with the pediatric. Talk about the underlying cause, especially to the PD situation. Also talk about early treatment of our seizure patients and also into burn patients on the pediatric side. And last but not least, the frequency, learn about the frequency and assessment and treatment considerations for pediatric overdoses, which is something we don't see a lot of, but we had a great case and the crew did an impeccable job taking care of this patient. So not to beat a dead horse, but we want to start off by talking about the pediatric seizures. Now, today I'm going to do a little bit of education about this stuff, and then we're going to get the crew to come up with Dr. Troutman and actually present the case and talk. So we're going to try to change it up even a little more than what we've done in the past. So remember, pediatric seizures, they are a little bit different from the adult side, especially because we have a lot of contributing factors to the pediatric seizure, mainly being fever. Typically, these fevers are above 101.3 is what the national guidelines say. But as we talk about it, it's not a matter of how high the fever goes, it's a matter of how quick they get there. So the mom may say, hey, 25 minutes ago the kid was fine, we had a big spike in fever, then the kid seized. The body's got to have some way of getting rid of that, so it chooses to seize. You also have metabolic changes in the body, congenitals, tumors, CNS infections, and head trauma being a big cause of the pediatric seizures. But the thing is, pediatric seizures don't always present like our adult seizures do. They don't always have that violent clonic-tonic type presentation as the adult seizures do. So for the next three slides, we're actually going to look at some seizures that are actually videotaped for medical purposes and were released to be able to be used for medical purposes. So we're going to call her Lily today. She was at a restaurant now experiencing frequent seizures. She does have epilepsy. So this is one of these things where we really got to use our family here, because when I look at this child, I don't see seizure activity. Does anybody else? I mean, you see a little bit of jerking, a little bit of movement, but for the most part, I don't see a full-blown seizure. This is where I'm going to need to talk to my mom or my dad on scene or the grandparents, and they're going to go, this is her typical seizure activity. Is that enough to buy off to where we're going to give her a benzo? You bet. Because we're going to listen to those family members of saying, this is her typical seizure right here. And you can see she's actually, they're securing her head, just trying to prevent any jerking or movements, but you don't see a lot of full-blown clonic-tonic type seizures with this pediatric patient. This is a young baby having seizures that is a central nervous system issue. And you can see it's just kind of more of a spasm type seizure. Once again, me as the paramedic walking in, seeing this child looking at me, moving its arms, I don't see active what I consider seizure activity at this point. So this is the point of the mom's going to say, this is this baby's seizure. This may be, my baby has had absolutely no problems, and now we're starting to have this seizure type, this type of activity. And so you can see, that looks like just a baby kind of flexing. And so this may be an unusual movement for that baby, and that's where I've really got to be able to listen to my mom and dad once again. Okay, this is infancy, and this is once again an infant and an older seizure patient sometimes will actually have just the eye twitching, and that's all you're going to see. Once again, I see the child moving, but I see a constant ticking motion. Now, when we think of our older patients, sometimes this might be a drug overdose, a specific drug overdose that could be causing this. But at the same time, this is actually the seizure patient. So the mom says, hey, my child's having a seizure, and I'm looking at it as the paramedic going, I don't see a lot of movement here. And they said, well, you see the ticking. You see the constant eye movement, And that's maybe that type. So is that enough for the paramedic side to say, I've got to kick in and I've got to respond and I've got to be able to give this child some benzos at this point? So we start talking about assessments. We start talking about, general things we need to ask the patient, or we need to ask maybe the parents if the child's not able to speak. Fever. Has the child been sick or anything lately? No. The child was absolutely fine, and I came back in and I noticed a full-blown clonic-tonic seizure. The kid has not been sick lately at all? No. Well, when I go down to touch the kid to move the kid, I notice the kid is very hot. That is a very common occurrence. That's probably one of the biggest things that we see. Next, the fontanals, and I'm actually going to move forward here just a little bit because I want to talk about the fontanals just a little bit. And you're going to be able to see these child. Now, this is, I would, in my opinion, this would be a grossly, this is probably one of the fullest fontanals I've ever seen, personally. Troutman?
Yeah, I agree.
That's huge.
I would look at that and really question if that's a fontanelle or some sort of, I'm blanking, I hate to say growth, but like a fatty, I'm totally blanking.
I have one of those right
Yeah.
there. Right
Yeah.
there? Yeah.
Right.
I have one in
I
the
would
back.
think that it's something else.
It's
not
okay.
fontanelle.
That wasn't meant to be funny, Cassie. Thank you. So this is a grossly inflamed. So what does that tell you about ICP? ICP is probably going to be fairly high with this kid because this is something that I've got to be able to recognize. Next, we have the depressed or the sunken in. What does that tell you about that child? I'm way behind the 8 ball because now I know I have probably some severe dehydration going. That could be my seizure cause from the metabolic side or the metabolic altercation side. So I've got to be very, cautious of a malnutrition child. So I've got to really be able to key off on these things. Guys, this is something that we don't always pay absolutely attention to, but every child, especially at the infant age, you need to be running your hand over the top. What are we feeling here? Okay, it's not sticking this way, but just running your finger. Is it full? Is it sunk in? You're going to be able to feel that immediately. About what age does that close?
12 to 24 months.
Okay, so you're going to have all the way through the infancy stage, you're going to be able to use that as a great assessment device. Next, you have your petechial hemorrhages, or your petechial rashes. Guys, this is going to be your infections. This is going to be your underlying cause of things, or a reaction to antibiotic. You may see this little red rash throughout the body. Real quick, I'm going to go back just a minute. Blood glucose. Guys, this is something we don't always check. Our blood glucose is on our little babies, but remember the heel stick is the most appropriate spot for that to get that blood sample. Any development delays? Yeah, it's one of those things we need to ask our family. Family, have you noticed, where are we at? Are we crawling? Are we, and kind of have a general idea of what age that should be starting. And last but not least, any bruising or other signs of head trauma. Sometimes, guys, kids are going to be bruised up. Kids are going to be running through the house, slip and fall. But if they're slip and fall and they've got a little bruise, that's one thing. But if they've got a depressed skull, that may be a whole nother, that's probably not a slip and fall. That may be something bigger.
All right, this call was a 3-year-old call by the mom. Stated the kid had a history of seizures. Seized for about 25 minutes before calling us. Said he's got a history of them. Denied kid being sick or anything like that before. Has been taking all of his meds as prescribed. We get there and he is having a full body seizure. Fires on scene. Already had a kid on some oxygen. We immediately just picked him directly up, carried him into the ambulance. It was like 1 week after our last case review, so we went directly to that IN for SED. It took a while. It took probably 5 or 6 minutes. I was just getting ready just to redose him when it finally stopped. Had a little bit of problems getting the IV. We finally got one in or out. By the time we got there, he was starting to respond a little bit to painful and starting to have some purposeful movement in all of his extremities.
Did you give an IM Versed before?
That was my first one.
What did you think?
It worked. It took a little longer than I was expecting it to, but about 6 minute mark is when it finally started to stop the seizure like activity.
Awesome. Do you feel like you could have got an IV and got IV meds in
No,
quicker?
not even.
That's tough,
He
right?
was a 3-year-old actively
seizing.
Yeah,
I mean,
it was difficult to get it.
if things would have went perfect, maybe. Even IV is, and I think you've got a chart in here somewhere. You're still talking 2, 3, 4 minute.
Yeah, absolutely.
And like you say, it's probably going to be a hard stay.
Yes, he was. It was very hard.
Cool.
Okay. So I want to bring up a point because this is another call on a 3-year-old, and we're not going to. The crew did nothing wrong on this one. They still followed appropriate protocol, but this was also a 3-year-old that began to seize, and this one was only 10-minute mark. Okay, what was yours?
25-minute mark.
25-minute mark. Okay, so what did we learn last time about the GABA receptors? We learned that they retract. Okay, and the longer we seize, the more they retract, and that's a less chance of my benzos getting on board. So 5 minutes felt like eternity for that kid to continue to seize. Okay, but they're working on an IV and not able to get one. So this crew decided they were going to try IM medication. And you can see the Versed was at 2013. They repeated it so we got 7, 8 minutes later, this kid's still seizing. We're going to do another IM injection. Once again, IM and IM. And at minute 2028, so now we are 15 minutes in and we're still seizing at this time. And so you can see that IM, that's part of the point of this. The crew followed protocol. That is in the protocol for them to be able to do that. But you can see that it takes longer for that to absorb into that muscle. And if we're able to use the IN, that's going to expedite that process. Now, it still took 5 minutes because you have the absorption of the IN, but you've still got to have the time for the GABA receptors to accept the benzo and to stop the seizure activity. So you can still see they did a great job by being very quick and being very aggressive with this. Okay, and that's part of this next time. We just wanted to remind everybody, like we talked about, the longer we seize is the longer it takes the GABA receptors to accept that benzo, because they're going to draw it back into that tissue. And so we need to get that on board. So if the mom's telling you 25 minutes we're in seizing, that's a long time. But the kid had a seizure history. That's not uncommon for a family to stay and say, well, they'll stop. Or a lot of times the family has medication at home that they try to self-administer, and then the seizure not stop, and then they call the 911 system, and we have a further delay. So you just got to remember that those delays sure add up to how we're going to be able to treat and take care of this patient. Okay? This goes back, I know we posted this last month at the case review, and this is something that we wanted to show you again. You were in the time frame of 2 to 5 minutes for the effectiveness of IN Versed. Okay, once again, 5 minutes seems like a very, very long time, and it is when you're sitting there watching that child seize. You're working on trying to get an IV. So let me ask you, if you would have had an IV, if you would have got an IV after the IN, would you have redosed a little quicker?
Probably, yeah.
Okay, probably so. Okay. And so that's one of those things that we're going to weigh of how quick we can get that. Once again, on the intermuscular, 80% peak at least about 5 minutes or so. And then once again, the intravenous, this is going to be the IV, that's going to be, of course, our quickest method. But you can still see by the pharmacology books, it's still saying 2 to 2.5 minutes for it to peak and stop a seizure. So the benzos are still going to take some time to work, but they're the fasting agent that we have. The Versed is going to be the fastest agent we have for that. Now, Versed not always a typical drug that we're going to use if we have an IV. Remember, we have Ativan, we have other options. And do you have a preference on what you would prefer if you have an IV?
I personally tend to give Ativan, but I don't think there's anything that justifies that it's better than Versed. So I'm good with whatever you guys are comfortable with. But if the patient sees in here in front of me, I'm going to use Ativan because when I was in residency, that's what my attendings use, and that's what I use. And literature-wise, I don't think neither is supported better, right? Not that I've ever seen.
Literature-wise, they're all equal. Just remember, your Ativan is going to hang around for about 6 hours versus your Versed's got about 20-minute half-life inside the body. So you're going to smooth those neural synapses out a little bit longer with the Ativan. So it's always an option for you.
To me?
Yep.
So, just stay seated. So we just talked about, Versed, IN or IM. probably the best route to do when we first come into the patient. I think somebody's actively seizing, it's very difficult to get an IV. Certainly when we're talking pediatric, even an adult can be very difficult whenever they are actively seizing. So don't forget the IN. Certainly, seem to overlook it. I think we're using it more and more, hopefully because we're just talking about it more. Even in the emergency department, I don't know that I think it's probably underutilized. We probably need to use it more in the ER. Somebody's seizing, we got 7 people holding the patient down while 3 nurses are trying to stick them so we can give them some Ativan or Versed. We probably need to be using more IN there. Early termination is important. I think we've kind of already battered on that. We understand that the longer somebody seizes, the harder it's going to be to get that seizure to stop. I think you bring up great points. We tend to, if it's a first seizure, we're probably getting that 911 call very quickly. If it's somebody with a history, it depends, because just like you said, well, he's seizing again, let's wait a second, or let's give whatever our diazepam or what medication we have at home to try to break it. So it may be a little more extended out. Like in this case, he probably had like 10-15 minutes till we called 911 until we got there, 25 minutes. So that happens. So the history of seizures sometimes do tend to be a little longer until we get there. And I just want to reiterate, always consider trauma abuse. Even on a repeat seizure, certainly pediatric that seizes, think about trauma abuse. We're the one there that can possibly be an advocate for a possible abuse case. And there are many children that present to the ER with seizures that are an abuse case, and we want to identify that. Any questions on pediatric seizures? I know last time I think we talked more febrile seizures. Those are very scary to parents. They tend to be less of an issue for the actual child. But this time we're not really focusing on febrile seizures, but all seizures can potentially be serious.
Thank you, Tyson.
Yes, sir.
What about Valium? What's y'all's thought process behind that?
I'm not a big Valium guy, just because half-life of Valium is only about 7 minutes.
Okay.
So you get more buy-in with your Versed and a lot more buy-in with your Ativan. I personally think it works better, but not saying if they can, in my personal opinion, if they continue to seize, then, and Ativan's not working, definitely. You've got that tool in your toolbox, use it. It may be something that patient's just specific to, but I would venture to say that across the board, Valium is probably becoming less attractive or less used in the medical community as a whole emergently.
Right, and that's something, because I know it's given some pre-hospital and EMS. I'd really never seen that given in the ER. I've seen Ativan, I mentioned a lot, occasionally Versed. It's not to say you can't give it, but I don't think it's probably the best. There's other adjunct things like, we have ketamine, and we're not giving ketamine currently for seizures. I'm not saying that, but that is becoming a later line medication. Maybe at some point we will. Ketamine and also propofol. And I know we even have some patients in town, seems like propofol is the only thing that will stop their seizure. So I don't know why that is, if it's people their bodies getting used to the benzos, I don't know.
What about using, because obviously anybody under 5 years old that's having a seizure, they're going to be a hard stick regardless if they're actively seizing. Whenever I worked in the pediatric unit, and in my experience, if I can't get a line, I use Valium rectally, and it stops it within about a minute. You use 3cc, use an angio cap, take off the angio, stick it up. And it stops the seizure pretty quick.
Are they using IN stuff now?
Okay.
Pediatric units? I don't know. I'm asking the question. I know that the PR Valium has been kind of a long-standing and certainly something to administer for that type of situation. But I think probably, I can't say for certain, but I think if we went to the pediatric units, I bet they're using a lot more IN now. There's risk anytime we place something in there. There's a risk of causing injury to that area and such, much less of doing that problem with using the nose.
Any other questions?
Is there less uptake with the little kiddos when we're doing the IN, like doing the atomizing class? Because it's a huge plug. Usually it works great with the adults to get them to kind of do the sniffing in, but we don't have that. Does you have less uptake?
Yes and no. The literature says that on the kids, it's still, because typically they're going to be in a supine position, so you're going to get that natural drainage to the posterior aspect. And so that's going to be more of a natural thing. Yes, it's always better if they can give a good drip, with it. Now, that's padded, all the way to the very tip. So it only takes just that little bit of first in because it comes out just that very tip of it. So I have not seen any literature, though, on the actual part of the breathe-in section of that. The absorption time is, by the pharmacology book, is about 20 to 30 seconds, is what they say the nasal should be absorbing. Now, once again, you still got to get the medication through the system and working where it needs to be working.
And I'd like to look at, I haven't looked at the actual package insert. I mean, what does whoever sells the device, the atomizer, what do they recommend? I don't really think there's a recommendation of having to sniff, right?
No.
This is all, theoretically, if you haven't, or maybe I don't know how much those things are, don't just open one, but if you shoot it up in the air, kind of mist. But that's all, it's supposed to be up in the nasal passage. You're not really sniffing it down into your lungs or something to be absorbed.
That's why we want that nice brisk push.
Yeah.
Because you can sure see it goes from just kind of spitting it out to a full atomization and get it way up in there. And atomization is a word. It's in the book of Chad, so I probably made that one up, but I like it. All right, any other questions on seizures? I know we've kind of beat this dead horse too much, but this is important, okay? All right, so let's talk about, Chris, if you want to come up, start getting ready. So we'll talk about the toddlers. We turn our head for 2 seconds and what is a kid into everything that they shouldn't be in. So one of the things that we see in kids is possibly getting into overdoses. Some of the literature suggests that 95% of kids under the age of 6 years of age has been into something they shouldn't have been at some point. That's a pretty high number. Now, fortunately, we don't see a lot of EMS where they're really sick, but we're going to get to see one today. Some of the largest number of kids who die or require hospitalization get into prescription medications such as opioids, sedatives, and cardiovascular drugs are kind of the main big heavy hitters. So grandma's keeping the kid for the weekend and gets into the grandma's heart medication, and so you never know what that's going to add up to be, and so we're going to talk about that. It's all yours.
On this one, it was not in our regular part of town. It was the day that there was the big wreck by the apple orchard at Idalou, and we caught this one late, and it was way on the east side, so we went way out of our normal area, I think all the way from Station 2 to just inside the east loop. And Engine 5 was there for several minutes before we got there, and I guess had made initial patient contact. And when we got there, they were carrying the kid out to us and saying that they had found him initially unresponsive in the house. And apparently this kiddo had been unsupervised and had gotten into some clonidine. And it was a real sketchy situation because this kid was apparently being watched by grandpa, grandma, well, maybe not watched so much, but got into this bottle of clonidine. But at the same time, this bottle had been filled in February, and this was early June. And apparently somebody had taken some of it sometimes, and so we, out of a bottle of 90, 17 were missing, and we don't know how many of those have been actually taken, and if any were ingested. And I mean, initially when they walked out, they handed me a crying kid, and so I'm thinking maybe not got so much, I'm just trying to gather all the facts and figure out what's up. And we get this kid in the back, and he's crying, and he doesn't want anything to do with me. So I was kind of suspecting that he didn't have very much in, and maybe the initial, I don't want to say I wrote off the initial unresponsiveness, but I was kind of thinking maybe he's come around now. If he did get some in it, he's awake enough that we're kind of past that point. So I got an IV and got him on the monitor, and we got going to the hospital. And he's crying, and then I don't know, maybe 2 minutes into transport, he exhibits, he stops crying and appears to go to sleep. And I kind of looked down thinking maybe he'd just gotten comfortable, but then he had little tactile stimuli, wouldn't bring him around at all, and kind of continued trying to, even little sternal rubs, stuff like that. Could not get this kid to come around. I mean, other than kind of just a very, very lethargic response. At that point, we upgraded. We started to see also, and I don't know if we can pull it up here, the EKG.
I can't.
Okay. We started to see some interesting dysrhythmias on the way to the hospital, and I can't recall specifically what all was going on. It was mostly irregularities and some wide complex stuff going on with him, and just persistently lethargic, withdrawn throughout the rest of transport. I tried to get on the ball pretty quick about calling Women's and Children's to let them know that what was going on. There wasn't really a whole lot for me to do other than just have some fluid going and just diesel therapy. And so that was basically all we did, was just get him up there quick. But it just kind of shows that some of the stuff you kind of maybe initially kind of ride off a first impression of he's crying, he seems okay, and maybe he did take him, maybe he didn't, and he definitely went downhill. There was potential to go downhill pretty quickly. That was pretty much the gist of it.
So let me ask you, how bradycardic are you willing to go on a kiddo that, how old was this kid again? Like,
I've got it here, but I didn't print it out. I can't find it. I think it was, I want to say 3.
yeah, I think it's 3 years old.
Just said toddler in here.
Yeah, we had to,
Yeah.
so you got a 3-year-old. How low are you willing to let it go bradycardic before we have to start addressing the issues? And then Dr. Troutman, the question is, if we do decide we need to address these issues with a calcium channel blocker on board, what is your choice of method to fix that?
Well, let me ask this. So, first of all, I'll say you did a great job on documenting and like you said, very sketchy of how many clonidine did we take. We documented, looked up to 17, and you're right. So many of these pediatric ingestions, and I actually had a call from my wife's sister, said her toddler was under the table at like El Chico's and had a pill in his hand, and she's freaking out. I don't know if he could have found 2 of them and took one. What do you say to that? Just take him home. If he acts normal for a while, he's probably fine. So, and even you said your initial impression was like, this kid's fine. He's fine. But then he's a teenager. So it's hard to tell sometimes on kiddos, especially toddlers. They can be a little bit crazy. So, big question I have. So, clonidine. Do you know what the antidote or what we give for that? Have you done any research in that?
No, I haven't.
Does anybody know? No. Y'all all have it. You give it quite a bit.
Calcium.
Narcan. Narcan's like the antidote for clonidine overdose. Now I wouldn't expect it for us to give that, and even in a true clonidine overdose, you don't necessarily give Narcan. You just when you think about overdoses, I think it's always odd. You can read about, well, what's the antidote for this overdose or that overdose? But most of the time in reality, what's the treatment? Supportive care. It's IV fluid, it's oxygen, maybe it is a little atropine or something for bradycardia, but very seldom do you actually give the antidote. But, so your primary question was the bradycardia, would you have done something? I don't think I'd have given anything. Not at 3, because he was still at 80, 90. If this was an 8-month-old, yeah, that's different. Or 2-month-old, very different. But I think we did right. This is a more diesel, and for the most part, he just needs reserved for a while. If he truly took 17, that's a lot. That's a lot. Chances are He probably did take some, but I bet he didn't take that many. Kind of get at what you were asking.
Yeah. What about if this kid's sitting at 52 and blood pressure's in the dirt?
Just a matter of atropine or pace.
Atropine or pace? Okay, and fluid first.
Yeah, I guess fluids for
Supportive
sure.
care, take them up, get a lot of fluid and stuff.
You know, to me, it's also maybe one of the rare instances. I would say call med control is Narcan, something we should give. I don't know how many folks you call in if they're going to have to do that. They said it is a, and it's not a, it's listed as a treatment for clonidine overdose, and you can give it, but it's not a clear antidote. Like, don't give it; it just magically reverses everything.
One of the biggest points is Chris is very proactive here and got his line early.
That,
You know,
that's
he had,
huge.
it's huge because,
You could have said, "This kid looks
yeah,
fine,
this kid
man.
looks just fine, he's
Nothing wrong with
crying.
this guy."
And maybe, you know, it was when fire picked him up, stimulated him some. Okay, that got him going. That got his, you know, endorphins back going, got him back stimulated again. Well, then when we got in the truck, got relaxed. But he was very proactive, and I thought that was a very good point. Get him on the monitor if you suspect it. I mean, you've got a very potent drug, and they were very proactive with doing the right thing and getting that line early. Okay, let's do this prophylactically. A lot of times we're thinking, oh, well, I'm never going to use this line, but at least I have it. And right there probably would have saved you if he got any further, any deeper weeds.
Yeah.
So kudos and very good
You were
job.
ready.
Okay. Any questions, comments? All right, last but not least, Chance Banks.
Come up there.
Yeah, come on up. Okay. So, talk about pediatric burns a little bit. Talk about pediatric burns. Chance had a really, really bad burn patient here with his kiddo, and so we're going to talk a few things about some of the things that we need to do for him.
I don't know what it's called. It's been a while since we were in this call, but it was over there at the apartments on the east side. We got on scene. There's a bunch of adults outside screaming, hollering, real loud. It was real stressful. The dad said that he was holding this 2-year-old child, and him and the mom were arguing, and she had a pot of boiling grease on the stove, and she just turned around and chunked it at him. Well, when she did that, he was holding the kid, and it just burned the kid. It burned the kid
There you go.
on the stomach. Is second degree. That's my drawing there. I'm an artist on my off time. Second degree burns on butt and the lower stomach. First degree in the upper. The kid really wasn't in that much pain when we got there. I don't know if it was just from shock or what. It was borderline even code 3 transport. Really, to me, I probably would have just went 30-1 with him. But gave him pain meds and worked out good. Got an IV, gave him fluids.
One thing I'll mention here, whenever we think about burns, which in this case it was obvious that, you know, somebody was saying I threw hot oil on the patient, so it's, again, when you think about abuse, you want to look at, does whatever the story kind of add up to the way the burn is, right? So, you know, if somebody, like in this case, if they would have said, I don't know, can't think of a good example, but you know, if they say, well, they fell into the fire, but you look at them and they have kind of a nice line on their butt where it looks like obviously dipped them in boiling hot water, that doesn't jive with falling into fire, right? That's not how you fall into a fire. Just something to throw out there and think about.
But
So one of the biggest points here is, sorry, you can see his documentation is very, very detailed. He did a great job explaining, going through every part of his assessment. Even since, I mean, guys, you know, this is probably one of those that's got a high potential of going where? Going to court. And he's done a nice job, even stuff that there was nothing wrong with that. He documented it, he covered himself well, even drew himself some pictures. Okay?
Actually, go back to the documentation. Just like, you know, here we've got the several silver dollar. Now again, this adds up. Somebody threw oil, there's spots of burns on them, so it adds up.
big spots. He even drew some little spots, silver dollars, I guess is what those were. And guys, pictures are appropriate. That's why we have this portion of it. You know, not a lot of people use their drawing portion of the Zoll program, but we do have that available for a reason, to where you can, sometimes it's easier just to draw pictures in color than it is to try to explain it, but he's done both here. He's done a very nice job talking about pain management here. Once again, morphine is still kind of the, I guess, go-to drug for burns. Now, also remember, we still do have fentanyl, and you also do have the ability to still call for ketamine if that patient is burned severely, severely bad. And those doses are increased for your burn patients in your protocol. That's a very good point. But once again, Chance has done a great job documenting. Therefore, he did get report of the month, and for Chance, it is the Tractor Supply, which fits him perfectly. So there you go. So, all right. Any questions on pediatrics, guys? I know it's one of those hard things. We don't run just a whole bunch of pediatric calls here, so it's really hard to pull a bunch of good calls for it.
Sorry, buddy.
Does anybody have any questions for Dr. Trout? Go ahead.
My personal experience with my daughter is in seizure, anti-seizure medications, or to stop them, is rectal administration just not socially acceptable in emergency medicine, or why? If it's a better route with better absorption and quicker, why is that not an option?
I mean, it's certainly an option. I guess show me the literature. You know, my understanding, everybody's moving towards IN is better.
I think, and what I've read, it's just socially you're at 70 to 90%, which, you know, who is that with my daughter, 70% absorption? I'd rather get as compared to the rectal. So I didn't know if it was just a social norm, or if there was something new out, something different.
A lot of the
They're having to up the dosage to get the same amount of medicine in the IM as the rectal. And I was interested in IN with my daughter, because that would be easier for at school or when we're out than somebody.
The absorption, the literature says, and now literature is one thing and practicality is another. So the literature really says the absorption time is 20 to 30 seconds nasally,
Right.
and about a minute to 5 minutes rectally. There is actually a study out that is actually talking about rectal volume and the potential of necrosis from entering something in and if you nicked or had a little something, I mean, you're going to cause more problems at the end of the day. Safer, a lot more accessible. You know, you don't have to get the kid naked, get them into a position, a squatting position, you know, introduce the medication, and then you kind of got a plug. If not, you're going to be wearing it. This is very quick, easy, hold them down. It's a lot cheaper. The dose is the exact same as IV, so there's no recalculation. So that's why a lot of places have gone to it, is mainly for the safety aspect. You're not introducing something into the rectum and running a risk.
It may absorb less, but you have less less probability of damage, and you have quicker absorption. Even though it's
Quicker absorption, and it should, but it's still, the drug's actually going to see how long it takes to absorb. Like Versed is going to be peak at about 5 minutes. And so we know that literature. Valium, I'm not for sure the peak time of Valium off the top of my head. Kim?
It's longer, but
It's a little longer than actually Versed is by literature portion.
I mean, there's absolutely case reports of having rectal wall compromised by doing that, and without a doubt. You know, that's extremely rare.
Is IN medications available to families? Or?
I know you get IN Narcan because police departments all over the United States.
Yeah.
carry them.
Good
The
question. I don't
device
know.
Is accessible, yes, and I'm sure it's just a matter of getting your doctor to write the script to that form. And in fact, I probably would guess it would be the exact same form as you'd get for the rectal. 'Cause it's
Yeah,
just
all you
basically
need is the
script.
atomizer.
All you need is the atomizer.
Yeah.
Same absorption time.
Good
That would be
question.
my guess. No, I'm not, but my guess would be that. And the atomizers are not expensive, like 60.
$5.
Oh, they that much? $5?
$5, $4 or $5 cheaper than the rectal syringes.
Probably so.
Yeah.
Pretty cheap. But in my opinion, it's a lot safer. I'm not a component for rectal medications.
When is the one time that you may have to consider rectal volume,
Great point. Facial trauma or
Or-
snotty nose.
snotty nose.
Snotty nose is not gonna work good, you're not gonna be able to get it in. It's just gonna absorb the snot.
Does it have to be gel in here?
No, it's just liquid, it's normal liquid, just like you give IV, that's what goes nose. But if they have any facial trauma, yes, that's one time that we can't do the nasal, or if they have a long history of drug abuse, that could possibly have a septal defect in the nose. Besides that, I mean, those instances are very rare.
Well, how about newborns that are not breathers?
Do what, sir?
How about newborns that are not breathers?
Yeah, and remember we talked about, it's not a matter of that, it's just a matter of atomizing it into those, into the mucosa there and let them absorb in. So it shouldn't be a big issue with that suck part or the inhalation part.
Yeah, the so-called, the breathing in, and I agree, I think you give it to an adult, ask them to sniff it, it's not gonna hurt. But that, the atomizer and the pressure is, like I said, if you just do it, it kind of blows it up, a foot or so. That action is getting it all up into the nasal passage. That nasal passage is allowing the absorption, much like the rectum or the distal large intestines. That's an area where stuff can cross the barrier. Same thing in your nose. Kind of a weird way to think about it, but comparing the nose to the large intestine.
Okay? Any other questions, first of all? Okay? What do we do?